Texas is adding residents at a pace that stretches local infrastructure to its limits. Every new arrival becomes a patient in an overloaded medical system. This line graph maps rising patient demand against the Cicero Institute's workforce projections, revealing a 20,400 doctor shortage by 2030. Furthermore, demographic breakdowns show nearly 30% of Texas physicians are within retirement range. There's no pipeline large enough to replace them. That shortage is already being felt on the ground today. Currently, 40% of Texas counties cannot meet their basic primary care needs. For a mid-sized outpatient practice, this creates a brutal math problem. When the labor pool is this shallow, every open position at an independent clinic competes directly against massive hospital systems, offering hourly wages and stability that smaller practices cannot realistically match. Relying strictly on the local, geography-bound labor market to staff a clinic in Texas is becoming a mathematical impossibility. The exact moment a front desk employee hands in their 2-week notice, the staffing spiral begins. Remaining staff scramble to cover phones, patient scheduling starts slipping, the workload compresses, and billing errors start showing up. This flow diagram illustrates MGMA's 2024 data, showing front office staff hitting a 40% turnover rate. At the center of this cycle is the financial penalty. Replacing a single position drains up to $12,000 from the practice. It takes a toll. Over half of medical group leaders nationwide now list finding qualified candidates as their absolute top operational challenge, placing it ahead of compensation and retention. The Bureau of Labor Statistics projects that demand for medical assistants will grow another 15% over the next decade. The candidate pool is actively shrinking as demand scales up. Meanwhile, your most experienced staff pay a hidden training tax. Every time the door revolves, they stop doing their actual jobs to bring new hires up to speed on specific EHR quirks and payer rules. If a practice limits its hiring strictly to a 10-mile radius of its office, it is actively choosing to absorb high turnover and constant replacement fees as a permanent operating expense. The lack of staff would be easier to manage if the volume of daily paperwork were actually sustainable. It isn't. Physicians are now reporting an average work week stretching to nearly 58 hours. This pie chart breaks down those 58 hours. You have 13 hours lost to indirect patient care. But look at this 7.3-hour slice pulled out entirely. That is time physicians spend every single week on pure administrative tasks. The heaviest anchor pulling those hours away from patient care is prior authorization. When we transition to this bar chart showing the staff impact, the time sink becomes obvious. Doctors handle a median of 43 prior authorization requests a week, forcing billing specialists to burn 11 hours and managers 5 hours just processing the approvals. That time translates directly into overhead. Between 2019 and 2024, practice spending specifically on prior authorization staffing spiked by 43%, even as reimbursements lagged behind. Practices are paying premium local wages just to manage non-revenue-generating paperwork, forcing highly trained clinical professionals to operate far below their credential level. A growing number of clinics are decoupling their back office from the local Texas labor market entirely. They are delegating this work to dedicated virtual medical assistants. There is a critical distinction to make here. A standard virtual assistant handles basic data entry. A managed healthcare VMA is a dedicated, offshore professional trained specifically in medical workflows, operating directly inside the practice's native EHR under strict HIPAA compliance. For this to work, a practice has to do some upfront heavy lifting. You have to clearly document your scheduling and intake protocols so the process lives in a system, not just in an office manager's head. Once those rules are set, modern VMA providers layer AI into the workflow. Intelligent task routing automatically matches specific authorizations or scheduling tasks to the remote specialist with the highest accuracy rate for that specific job. This diagram shows AI anomaly detection as a safety net. As tasks move along the workflow, an AI lens scans data in real time, automatically flagging unusual patterns in red and routing them to human reviewers before becoming billing errors. A managed structure like Staffingly also builds redundancy right into the contract. If your dedicated specialist calls in sick, a cross-trained backup automatically covers the shift, eliminating the single point of failure that usually cripples a local front desk. The trade-off is straightforward. You give up the ability to physically look over an employee's shoulder in the office, and in exchange, you get a strict, AI-assisted, and highly measurable system that runs consistently. Ultimately, evaluating this remote infrastructure comes down to the raw math. An in-house Texas hire fully loads at $60,800 a year when stacking salary, benefits, and overhead. Conversely, Staffingly's dedicated VMA runs $21,600 annually for 45 hours a week. That's a 64% reduction, saving $39,200 per position. The operational safeguards are non-negotiable. The vendor must carry HIPAA certification, SOC 2 Type 2, ISO 27001, and connect securely to major platforms like Epic, eClinicalWorks, and athenahealth. The entry barrier is practical. Practices complete native integration and go live within 48 to 72 hours, operating month to month without long-term contracts. The healthcare labor market in Texas is not going to correct itself. For mid-size practices, the real operational risk is no longer testing a highly integrated remote workforce. Instead, the real risk is stubbornly fighting an unwinnable talent war on local ground while your margins slowly bleed out.